Hi, welcome to this Medscape sponsored program, which is transforming gastric and gastroesophageal junction care with perioperative immunotherapy with updates from ASCO 2025. My name is Dr. Zev Weinberg from UCLA, and I'm pleased to be joined by my good friend and colleague, Dr. Yelena Janjigian from Memorial Sloan Kettering. The recognition that gastric and gastroesophageal cancer is a disease that is sensitive to immunotherapy has led to a lot of improvements in the advanced setting. However, we now want to take some of those advancements and see if they can work in the perioperative setting. So we'll be reviewing today some of the perioperative studies, particularly from ASCO 2025, and at the conclusion of that, there will be opportunities to ask questions. We recognize that gastric and gastroesophageal junction cancer's 5-year survival still has significant improvement that we need to do. In reference to colorectal cancer and breast cancer as examples, our 5-year overall survival rates barely exceed 50%, and that includes patients with early stage disease. We also acknowledge that there is no clear global standard in some respects, so there's necessary requirements to sort of standardize a reference regimen that can be adopted globally. The standards of care for resectable gastric and GE junction cancer is what we'll be talking about today very briefly as an introduction. When it comes to squamous cell carcinomas and esophageal cancer, there has been an expectation that there is a standard, which is neoadjuvant chemoradiation with the so-called CROSS regimen, carbotaxol and radiation, followed by surgery, followed by, in some respects, adjuvant nivolumab. When it comes to gastric and GE junction cancers, and even esophageal cancers, we've seen in the last few years that there has been some coalescing behind FLOT, which is a perioperative chemotherapy regimen consisting of 4 drugs in preoperative and postoperative contexts after gastrectomy. We know now that this has been acknowledged to be a reasonable standard of care across the globe, even in Asia, where historically patients were taken immediately for gastrectomy and got adjuvant chemotherapy. There has been some recognition by the guideline committees around the world, which include the United States, Europe, and Asia, that perioperative FLOT is indeed a reasonable standard. So we know that chemotherapy only gets us so far. We know that the majority of patients do relapse, unfortunately, and those relapses confer a poor prognosis. So we need more effective therapies. And with all that as background, I'm going to hand over to Don, who will talk to us about some of the most recent exciting data with immunotherapy in this context.
Thanks so much, Zev. It's an honor and a pleasure to present this data. So by way of background, of course, we know that immunotherapy works in metastatic disease, and as you mentioned, gastric and esophageal cancer is a huge disease burden. 1.2 million people die of this disease and will die of this disease in 2025. So the purpose of MATTERHORN, and really the take-home message that from our study, is that anti-PD-L1 therapy improves survival when you add it to and combine it with perioperative FLOT. So the data really supporting this is based on a large randomized phase 3 double-blind placebo-controlled study. We enrolled patients with gastric and gastroesophageal junction adenocarcinoma with stage 2 to 4A disease with no evidence of metastasis, no prior therapy, and geographically, this was a robust global study with 20 countries participating worldwide, including Asia, Europe, North and South America. Patients were stratified by geographic location, clinical lymph node status, and they were enrolled irrespective of PD-L1 status and stratified by tumor area positivity, less than 1 or greater than equal to 1. 948 patients were randomized to receive neoadjuvant durvalumab on day 1, with FLOT given on day 1 and 15 of 1 cycle, and patients received 2 cycles of perioperative and neoadjuvant durvalumab with FLOT or placebo with FLOT, followed by surgery, and 2 additional cycles of durvalumab or placebo with FLOT, followed by 10 cycles of durvalumab or placebo for up to a year of adjuvant therapy. The key primary endpoint is event-free survival, and this was a final event-free survival presentation at ASCO in the plenary session this year. And the key secondary endpoints are overall survival, which is an interim analysis, and final analysis is ongoing. And of course, we already presented pathologic complete response rate, and we'll show you again today. And key secondary endpoint is disease-free survival. Event-free survival is defined as time from randomization to event or death in all patients from in intent to treat. And disease-free survival is time to disease recurrence or death in participants who had an R0 resection. The rates of treatment and surgery completion were similar between the arms. And if we learned anything from the study, is that FLOT is feasible to give globally. Nearly 100% of patients were able to complete all perioperative cycles of FLOT, and this number was similar in between the two groups. So addition of durvalumab did not compromise delivery of chemotherapy. And also the delivery of surgery, being able to do a complete R0 resection was not compromised. 92% of patients in both groups had complete resections. Patients in adjuvant setting, the delivery of chemotherapy was also better than we expected from historical prior studies. 77% of patients received adjuvant therapy. In fact, more than half, 52%, completed all cycles a year of adjuvant therapy, with 68% of patients in active follow-up based on the recent data cutoff. Baseline patient characteristics are well balanced between the groups. 19% of patients were enrolled in Asia. 32% had gastroesophageal junction adenocarcinoma, and 68% had gastric cancer. These were relatively advanced tumors. 25% had tumor invasion through the serosa T4 disease, and 69% were node positive. 90% of these patients had PD-L1 overexpressing in their tumor by TAP criteria, which TAP is very similar to CPS, and 5% were MSI high. These curves are exciting to share. The primary endpoint of event-free survival is met in the study, with significant improvement in event-free survival observed with durvalumab with FLOT versus placebo with FLOT, with 2-year event-free survival of 67% compared to 59%. The durva and FLOT group, the median event-free survival was not reached. There was an early and sustained separation on the survival curves, and with the placebo and FLOT, the median event-free survival was 32.8 months. Hazard ratio is 0.71, translating to 29% reduction in risk of event, which is progression or death. Stratified log rank p-value of less than 0.001. Looking at event-free survival in key protocol pre-specified subgroups, there was a consistent benefit, and we see that the point estimates for hazard ratio all favor the treatment effect of durvalumab, including patients who are 65 years or older, patients enrolling globally by geographic regions, and most importantly, patients with low PD-L1 or negative PD-L1 overexpression with TAP less than 1. Looking at the secondary endpoint of overall survival, and the alpha allocation was such that very little alpha was allocated to OS at this juncture, and majority of the alpha, 4.99%, was reserved for OS analysis. But what we do see is a separation of the survival curve starting at 12 months. And at 2 years, 76% of patients are alive on the durvalumab group compared to 70%, very similar delta to what we saw in EFS. At 2 years, median OS is not reached in the durva compared to 47.2 months in the placebo, hazard ratio of 0.78, with a p-value of 0.025, which did not reach significance threshold, as I mentioned, based on the alpha allocation. Of course, the pathologic complete response with durva plus FLOT is already been shown. It's improved with 19% with durva FLOT compared to 7% with placebo plus FLOT. And this difference is statistically significant. Key secondary endpoint of disease-free survival, because we do get questions from patients, why do I need to continue therapy if I had an R0 resection? And here you see a sustained separation in the survival curves at 2 years, 75% versus 66%. Again, similar delta in the benefit across these survival analyses. Durva plus FLOT not reached in the median DFS compared to placebo of 39.8 with FLOT, hazard ratio of 0.70. Treatment delivery was quite good, and the take-home message across these analyses is that really durvalumab did not affect FLOT administration. In neoadjuvant setting, nearly 100% were able to complete it. The median number of cycles in both groups are very similar. In neoadjuvant or adjuvant cycles, it's exactly the same. And most importantly, 73% of patients and 67% were able to complete all durvalumab and FLOT in the first initial 2 cycles, and 52% of all year of adjuvant therapy. The AEs were, as we would expect. FLOT is 3-drug cytotoxic chemotherapy, so most of the side effects come from the cytotoxic agent. Looking at grade 3-4 possibly related to any study treatment, 60% in the durva group versus 59% in the placebo, again highlighting that it's mostly chemotherapy-related side effects, with AEs leading to discontinuation of any study treatment. With durva, placebo is about 10% versus 6%. And looking at immune-related adverse events, which are related to durvalumab or placebo, grade 3 or 4 immune-related adverse events was 7% versus 4% in durvalumab and placebo. And what's important is that it did not lead to treatment, to an inability to do surgery, and grade 5 events were very, very rare. Common AEs, as you can expect, are related to neutropenia, alopecia, decreased appetite, and most common grade 3-4 events really all related to decreased neutrophils, because G-CSF prophylaxis was not mandated and was left up to the institution guidelines. In fact, FLOT administration in the protocol purposely was really left up to the local guidelines, and so the investigators did what they're used to doing with FLOT. And in conclusion, this data is important for our patients in perioperative setting. Durvalumab with FLOT significantly improved event-free survival compared to FLOT alone in resectable gastric and gastroesophageal adenocarcinoma. Event-free survival benefit was consistent across subgroups and geographic regions. There were no new safety concerns identified, and overall survival data analysis will be presented, final analysis at a later date, and the data so far is encouraging. So Zev, maybe you can take us now through the CheckMate 577 data, particularly the OS updates.
Thanks, you. And I think that it would be great. I think you made a really good point about the feasibility of the regimen, and how it, in your experience, and also for some of our audience who doesn't have experience, I wonder if you could comment on that a little more. Like, what are some tricks that are a good idea for patients to get them through this regimen?
Yeah, I think that's an important point. The timing of MATTERHORN is actually, the reading out is perfect, because it comes on the heels of ESOPEC and other studies that really solidified that FLOT is, the important regimen. Of course, New Ages also showed the radiation doesn't add anything to survival. So I think having MATTERHORN now makes people more comfortable with using immunotherapy in perioperative setting, because increasingly people are recognizing that FLOT is an option for perioperative disease. What we've also learned is not all patients are fit for FLOT. And in my practice, the way that I decide whether or not someone is going to get FLOT is really, are they fit for surgery? And if they're fit for full dose FOLFOX, typically we're able to get them through initiation of FLOT at least. And if there's concerns for safety or tolerability, I often dose reduce docetaxel from the beginning, and actually just drop the leucovorin dose completely, and also administer IV hydration at the time of the disconnect. And with the first cycle, I personally, and many in my group, tend to give prophylactic G-CSF just to see, what happens. If certainly we often keep going with it. Most patients require it, especially if you stay on a dose-dense regimen every 2 weeks and don't want dose delays. In some patients, if the white count is very high with cycle 2, we maybe do it intermittently or drop prophylaxis. But I think realizing not every patients need full doses, and also starting with some closer follow-up, and certainly really educating the patients on the important antiemetics. I make them pick up the prescriptions for delayed emesis regimens, day 2 or 3 dex before they leave, so they have Zofran, Reglan, Decadron would give them a mend in clinic. I think the nausea piece is also important, because once the nausea gets going, it's hard to turn that around. But also just educating the patients. It's very hard to predict who's going to fall apart. As you saw the range of the study, there was octogenarians treated on the study, 84-year-olds, and the 26-year-olds. I find sometimes it's the younger patients that are less compliant, and they're not used to being sick, so they don't call you or take the nausea medicines. Yeah. So I would, I often get that my 70, 75-year-olds are actually the best to tolerate sometimes blood, because they do what they say. They're used to listening to doctors, and.
Yeah, and I think, those are really good tips and good practical points, because as we get more experience with this regimen in esophageal cancer, now gastric cancer is becoming a standard, and adding the durvalumab did not have any negative implications insofar as getting the chemo in there, which is an important point. The other challenge, and I think we all recognize that the adjuvant part of the chemo after surgery is a little bit harder, obviously, and that's typical in just about every cancer. Getting them through adjuvant is a little harder than neoadjuvant, which all of those tips that you just made are even more important for our listeners in the adjuvant context, so that after gastrectomy, it's not the key thing is giving them effective treatment and not necessarily intense treatment every cycle. So if dose modifications for docetaxel, as you commented on, and making it easier for them in the adjuvant setting, it's important to keep all these things in mind. These things were done in the study, and so many patients who were enrolled on MATTERHORN, as you and I both know, had these dose modifications.
Absolutely. We allowed the investigators pretty much to do, the protocol was very bare bones, as you know. I wrote it with that intent, because I wanted the clinicians to be able to take care of their patients in the way that they wanted to. We didn't micromanage the dose reductions. I think the number one question I get asked is, can we just drop the dosi and do, FOLFOX IO in neoadjuvant setting? And I would be careful doing that, because I think there is some important component to the combination therapy. And as you know, taxanes have effects on tumor microenvironment and the immune response. So I do think you're better off doing dose reduced combination than, let's say, as I mentioned, full doses of FOLFOX and drop the dosi. And even just starting with FLOT with a dose reduction from the beginning, and then dropping or doing maybe, not even doing all FLOT components adjuvantly, which is, when we say chemo delivery, as you said, it's components of it, whereas some people may only get 5-FU durva adjuvantly, and that's okay. I think, so, we understand that some of these patients are being overtreated, and we're doing a lot of biomarker analysis to try to understand which patients you could scale back on. But just use your judgment. And I do think starting with combination is important, and most patients can get through some of it.
Well, thanks. I'm gonna just touch briefly on obviously some other important trials that were updated at this ASCO. And the first one is CheckMate 577, which, as mentioned earlier, enrolled patients after esophagectomy, either squamous cell or adenocarcinoma, who had gotten carbotaxol cross regimen neoadjuvantly with chemoradiation, and then randomized to nivolumab versus placebo. And we've had this approval in place now for a number of years on the basis of this slide, which shows a disease-free survival. And this slide was updated here at this ASCO, showing indeed that the curves do separate. You see some crossover towards the end, interestingly, but you also see that there's a doubling of the disease-free survival from 10.8 months with placebo with 21.8 months, and a statistically significant hazard ratio of 0.76. Now, the purpose of this ASCO was to show the overall survival. Because overall survival is, of course, a critical endpoint. We acknowledge that many of the patients who were enrolled on the placebo ended up receiving checkpoint inhibitors upon progression, which may explain at the end why some of these curves tend to cross over. But even in the beginning, you do see a little crossover happening very briefly at the 12 to 24 month range. So here, unfortunately, this did not meet statistical significance. The hazard ratio is 0.85 and the p-value is 0.1064. So while it did show a disease-free survival, adjuvant nivolumab did not show an improved overall survival, even though numerically you can see the improvement of the median from 35 to 51 seems like a lot. Unfortunately, that did not meet statistical thresholds. Now, if you start to look at the details of the subgroup analyses, you can see that the predominant driver of this was the CPS greater than 1 patient. So then the CPS less than 1 patients, which represented a very, very small group in the Matterhorn, as Yelena just showed. Here it represented perhaps a larger group, and here the median really favors, in fact, the placebo group for whatever reason. So, and if you kind of look at this, if you look at this on a Kaplan-Meier curve, you can see that if you just isolate the greater than 1 patients on the left, the overall survival improvement is significant. If you pull out the CPS less than 1 patients, which is the curve on the far right, you can actually see that at least numerically, the nivolumab showed a inferior overall survival compared to placebo. So I think this is, while this was a predetermined threshold, perhaps the numbers are small, so it's, you're having difficulty making conclusions, but it certainly is an interesting finding. The safety of this regimen, we've known for some time that adjuvant nivolumab, if given properly in the right context, can be safe, and there was no significant updates in the safety from this regimen. In conclusion, what the conclusion was, the disease-free survival was sustained, but the overall survival did not meet statistical significance, and the subgroups did identify the groups who may still benefit. And we'll talk about in a minute what that may mean for the future. But before I do that, I'll just update briefly on Keynote 585, which was read out last year and now has since been published. This was a very large perioperative study done globally. It did not contain FLOT except for about 200 patients. So here you could see this was the 200 patient cohort, which was a subset of the larger 585 study, which include 2 drugs, platinum 5-FU. Here, this subset, once FLOT became more adopted, was started to look at pembro plus or minus FLOT. And so what happened here was that this study randomized patients similar to Matterhorn to placebo plus FLOT versus pembrolizumab plus FLOT, but only in 200 patients. The pathological endpoints were met, particularly in the FLOT cohort, where you improve path response significantly. However, when one looks at the event-free survival of the overall cohort, this did not meet statistical significance. So what we saw here was that even though there's some numerical improvement, there's a big drop-off towards the end, and there's no statistical significant advantage of event-free survival, which was indeed one of the primary endpoints of pembrolizumab group over placebo group. And the overall survival curves are completely overlapping. And so this study was deemed to be a negative study. When it comes to safety, obviously that wasn't no surprises there either. There's obviously increased immune-mediated adverse events in the group of patients who get immunotherapy, but no big surprises in that regard. So the Keynote 585, this should read Keynote 585 conclusions here, were that the study, while having a numerical advantage in event-free survival and having a trend in the FLOT cohort in particular, did not meet statistical significance and thus is not considered a regimen that is now standard of care. Finally, just to end up on it's a busy slide, but the Germans have done a study looking at atezolizumab with FLOT. The Germans, as we know, started FLOT, and they've been using it for a while, so they wanted to do their own study with atezolizumab. The results, and I'm not going to get into all this because we don't have survival results, we only have pathology results and complete regression rates and pathology endpoints, but suffice it to say the pathology endpoints, just like in the Matterhorn study and just like in the Keynote 585 study, the pathology results from when it comes to downstaging, when it comes to complete pathological response, when it comes to major pathological response, all did favor the FLOT plus atezo arm, particularly in the patients who are PD-L1 positive. So what this will mean for the future, we have to wait and see the results of that study. Finally, when people get asked, what should we do after FLOT if they still have high pathological disease, so minimal pathological response, what do you do in your patients who have FLOT durva as per the MATTERHORN study, and then pathologically they have a disappointing response? They still have a high burden to the disease and they still have positive lymph nodes. The only study to look at that directly randomized patients after surgery, and they didn't get FLOT durva, but they got chemotherapy before, to either continuing that chemotherapy or nivo-ipi in the adjuvant setting. And this study was very negative. The group of patients in blue were the group of patients who continued on chemotherapy. So the group of patients in red were those who switched to immunotherapy. So there is really no data to give immunotherapy alone in this disease, perhaps outside of the MSI high subgroup, but there is really no data to give neoadjuvant or adjuvant immunotherapy alone outside of FLOT, of course, beyond the extended adjuvant phase in which FLOT tested durvalumab. So some of the things we talked about already is how do we identify patients? We talked about some of the things there. Is event-free survival enough to change practice? I think we all think it is, and we talked about some other trials that are ongoing at this time. There's a few questions, and maybe I'll ask Dr. Janjigian what she thinks is a patient with adenocarcinoma of the esophagus who should get cross now in place of FLOT plus durvalumab.
Yeah, I mean, to be frank, I haven't radiated an adenocarcinoma patient probably in close to 7 years. I think once we saw data from Nipiga and some of the other Top Gear and some of the other studies, SOPEC now, I mean, it's really, you're doing your patients a disservice by radiating them with carboplatin and paclitaxel. Carbotaxel is a suboptimal regimen for adenocarcinomas, and often I hear, well, the patient is not fit enough, or the disease is advanced, and we're not going to resect that, be able to resect it. So I would say two things. If the disease is so advanced that you're not going to be able to resect it, adding radiation on top of it is really classifying the disease, right? So you may need a more protracted course of systemic therapy. And if the patient is still not converting to resection, maybe you shouldn't be operating on that patient, because right, those patients are not going to be cured. They're going to recur. So for us to radiate someone just to pretend you're going to cure them is not how we're going to advance the field. So in the level one
really
evidence.
Unfit patients, Yelena, and the unfit patients who can't undergo surgery, we would just, I think systemic chemotherapy would be your...
I do FOLFOX Nivo and then monitor them. And as I mentioned, if you can get them a little bit of DOSI with it, that would be better. But if you can't, then I think FOLFOX IO is either Durva or Nivo would be, or Pembro or Tisley or whatever would be appropriate. I think don't radiate adenos, please.
Yeah, I think we think, yeah, I agree. I think carbotaxel followed by nivolumab, in my opinion, is the standard for squamous cell carcinomas and remains that standard.
Although now there's data coming out of China that chemo IO is with surgery is maybe better. So
yeah,
we have to see. What about what do you think about the OS endpoint in KEYNOTE-585? How can the curves be so superimposable?
I think that is the one thing, because we obviously, hopefully, we'll see an overall survival advantage proven statistically, and the curves just look so different in KEYNOTE-585 versus MATTERHORN. And I think, partially this is a product, I do think, of more effective chemotherapy. I do really feel like, as you mentioned earlier, this docetaxel is probably a more important drug than we gave it credit for, particularly in the adjuvant setting. So including in this regimen, I think, I remember, in one of the big studies to come out of Japan the last decade, and adjuvant chemotherapy was S1 docetaxel. It really was an effective adjuvant drug. So maybe there's something to do with that. I don't know. What do you think?
Yeah, I think we need, and there's a good JAMA article about this, we need to be very careful with not putting too much weight on the medians, especially in these perioperative study, and looking at 2-year survival is good.
I really want to thank the audience for attending, and have a good day.
Thanks, Deb. Good to see you. Bye.
Bye.